All right, guys, welcome to week five. There's a little bit of overlap between weeks four and five, which is part of why you actually don't have an assignment due in week four, because it does take a couple of weeks for us to cover all of the CBT, behavioral, and kind of related approaches. So this video, I'm trying to tailor it a little bit more towards your worksheet that's due at the end of this week. But if watching this, you start to come up with questions about cognitive therapy or behavior therapy, you're more than welcome to reach out or put it in the discussion board or leave kind of a class questions message, and I will be more than happy to look at those because, like I said, it's four major approaches that we're trying to cover in the scope of 2 weeks, which is a lot. I mean, that's a lot to try to put together all at once. So I'm going to walk through this one and try to just hit the highlights and give you a really good starting point for your assignment that's due at the end of this week. And then, like I said, if you have any questions, as always, feel free to reach out. Right. Um, so here's our agenda. So we'll talk about CBT, how it covers cognitive therapy, reality therapy, and then what the roles dysfunction change. We'll try to describe how each of these approaches conceptualize those. And then of course interventions, ethics, and I have homeostasis on here. I believe I kind of use this PowerPoint slide or these slideshow for topic six too. So homeostasis probably isn't in there. And I just realized it's behavior therapy and REBT are the topics in week four. So if you have questions about those that you want us to unpack a little bit more, feel free to reach out. But just make sure I'm saying the right ones. Yeah, it's behavior therapy and REBT. And then this week is CBT and reality therapy that we're looking at. Okay, so cognitive behavior therapy. This is one of the most widely recognized and widely used approaches for counseling. It really is an umbrella term. When people say they're using CBT, they're really talking about some combination of cognitive therapy, REBT. There's dialectical behavior therapy, and then acceptance and commitment therapy. So it's really some combination of each of these. You can pull in behavior therapy concepts, but I would still argue that CBT and behavior therapy, in the strictest terms, are not the same because behavior therapy does not address thoughts and feelings directly. It addresses behaviors and reinforcement, right? And that can eventually change thoughts and feelings, but CBT is a little more targeted at thoughts and feelings to change behavior, where behavior therapy is the other way around. It is by far the most evidence-based approach for counseling. I would argue still because it's really easy to study. There are things that you do, it's very structured, it's been manualized 1,000 times. And so it's easy to study and to look for fidelity and then efficacy, where something like existential therapy is a little bit more difficult to observe because when are you using it? When are you not? What are the exact interventions? Is everybody doing those interventions the same? Probably not, right? But for what it's worth, it is the most well-established evidence-based approach for counseling. So if you're looking for a good, healthy starting point, CBT is a great one because we know it works and we know why it works and we know how it works. And you can educate your clients on all of those things too, which is another piece that makes it beneficial. Um, yeah, so simple to learn for you and your clients. There we go. Okay, so cognitive behavior therapy. It is a blend of kind of psychoanalysis and behaviorist approaches. It does acknowledge that there's both an objective reality, so there is what is true, and a separate subjective reality or experience. And really, the key thing to take away is how we experience the same objective reality differently because we all have different thoughts, emotions, physical responses, and behaviors, right? So if you're both in the same situation, right? And maybe this person over here with anxiety, maybe they have a really traumatic history with dogs. Maybe they were attacked by a dog when they were a kid and they haven't been able to work through and process that. And so when they see a dog at a park, their first automatic thought is that dog will attack me because their belief about dogs might be dogs are dangerous or dogs aren't safe, right? Or I'm not safe around dogs. They have those beliefs, and each of those lead to these thoughts, the dog will attack me. And when you think something's going to attack you, how do you feel? Well, afraid, right? And when we're afraid, your body, your heart might start racing, or you might get sweaty or clam up, or your legs are feeling jittery, right? And so, what do when you're faced with a threat that feels dangerous and makes you feel afraid? You're going to run away, right? Now, without anxiety, so maybe a different person sees the same dog at the same park, right? But they don't have that traumatic history. They don't have the core belief that would make them feel afraid. And so they see the same dog and think, oh, what a cute dog, right? And then that makes them feel happy. They might feel energized or even calm. And what do? They walk over and pet the dog, right? This is really CBT in a nutshell. Okay. So where would we want to target our intervention? Well, the best place is the first place it shows up in the cycle, right? For this, it's pretty easy. So the dog will attack me. What a cute dog. The thoughts here are different, and we see how that affects everything else, right? So CBT, we might challenge the thought and, let's look at the evidence, or let's try to argue against it, or I wonder if we can reframe that. Even some grounding exercises, like, hey, remember, there was a dog that was worth being afraid of. Is every dog worth being afraid of, right? So if you can name the thought, that's usually the best place to start, right? A lot of people will not have the awareness to identify the thought, right? So then we look at the emotion. If that's the first place they notice, we go right at the emotions. So you feel afraid, right? Okay. And if you can, you work backwards. But if not, you do some grounding, you build some coping skills. So where this emotion doesn't feel overwhelming, right? So targeting where you intervene is usually based on the earliest point in this reaction that your client can identify. And if you can identify an early point for them, that's good, but they have to also believe that that's true, right? You can't tell them, oh, you have this thought. If they say, oh, no, I don't think so, don't argue, right? Like they might actually be having that thought, but if they can't verbalize it and see it, you're just going to beat your head against the wall, right? So let them identify it. You can identify the earliest place if you can, but they have to agree. Okay, so central ideas. So schemas, core concepts that work to filter and organize new experiences. So the schema, like dogs are dangerous, would be a schema, right? Or I'm not safe around dogs. It's a core belief, also a schema, because then when you meet a new dog, your maladaptive response right here is to want to run away, right? So beliefs, core ideas about self and others, and assumptions, rules and attitudes. I would really highlight this part of it. Core beliefs about ourselves are usually the most powerful, right? Like, I'm not safe. I'm an idiot. I'm no good. I'm worthless, right? All of those are core ideas and beliefs you have about yourself. Others can be impactful, but if we go back to our dog example, right? If I think, oh, that dog's mean, my assumption, my belief is that dogs are mean, right? If I change that to an I am statement, okay, that dog is mean, which means I'm not safe. Just which one of those do you think is going to feel stronger to the person in the situation, right? They might be pretty close to the same, but in my experience, the I am statements resonate more and feel a lot more powerful when we look at them. Okay, automatic thoughts. We've already talked about this a little bit, but automatic reactions to situations that can be functional or stressful. I would actually argue that they could be functional and stressful. You can be stressed out and still functioning. It doesn't have to be either or. Okay, modes, networks that make up personality and create shortcuts for interpreting situations. Now, what's important to understand is that these modes, all of these things that we're talking about, so schemas, beliefs, automatic thoughts, and modes, these all happen naturally. So it's not a problem if someone has a schema or has a belief or has automatic thoughts or has modes, right? That on its own is not a problem, right? Like REBT targets irrational thinking. We all have irrational thoughts, though. And so just because we have an irrational thought doesn't mean it's a problem. It's kind of like it's not a problem until it causes a problem, right? So if your network that you've developed, your mode down here, creates a shortcut that's helpful for you because you're accurately interpreting the situation and it helps you function and accomplish your goals, right? Or even like improve your quality of life, we don't really want to touch that, right? But if your automatic thought doesn't have any evidence behind it and it causes you a lot of stress and it keeps you from doing something meaningful or that you at least think you would enjoy, then that's the kind of thing we want to target, right? Like we all have these. So maybe this could be a fun exercise, right? Like take a couple days and try to write down all of the things, all of these four things that you notice, right? Maybe automatic thoughts and beliefs might be the easiest too. And then look at each one and just go, is that a problem? Right? How would my life be different if I didn't have this automatic thought or this automatic reaction? Or what if I believed something different about myself or about other people? And if it wouldn't change anything, okay, right? Or if it's functional and it helps you out a lot, we probably don't want to touch that either. But if you start reflecting and notice, man, I have this belief right here that holds me back from doing this thing that I feel like I would really enjoy. That's the kind of belief we want to start examining, right? Again, that's for you on your own, just as an exercise if you want to do it. I think it might be a good way to integrate some of what you've been learning. Okay. So state of dysfunction. Oh, and my mark stayed. That's annoying. Um, State of dysfunction. So we have it's not the event, it's the schema that filters the event, right? So a different way to say that is it's not what happens, it's how we respond to it. And um, if we respond to it with an unhelpful thought process, right? Or a negative belief or something that's just not true, that's when it becomes a problem, right? And really, that's kind of summarized here of like negative views of the world, or of the self of the world and of the future, right? Let me see. Okay, there we go. That's what I wanted. Um, So core beliefs shape roles and assumptions, which generate automatic thoughts. So if you're looking for the deepest level, it's the core beliefs are usually the foundation of how we think, feel, and behave, right? So if you can, whenever you can target the core belief, you're really getting at the root of the issue. And by addressing the core belief, you'll have lots of collateral effects where the thing you're working on might improve, and so might four or five other things that are not even on your radar that day because they're all connected. They all come back to the same core belief, right? Like, I'm an idiot. Nobody loves me. Well, if I feel like nobody loves me, I believe that to my core, what am I going to start feeling or doing around other people, right? How am I going to think about people when I meet new friends that I'm trying to make, right? Again, they drive emotion, behavior, some common distortions, which you can actually, and I would strongly encourage you, you can look up common cognitive distortions, like Google it, you'll find all kinds of resources. There's worksheets and stuff that you can look at. And if you familiarize yourself with, I don't know, pick five or six, if you know 5 or 6 that you can name and define and just kind of pull out of your hat whenever, that's going to help you implement CBT, right? Because it's a lot about knowing and naming and understanding the cycle and how to step in and interrupt it. Okay, so cognitive therapy also targets beliefs. CBT adds the behavioral component that is missing from cognitive therapy, right? So where we might catastrophize and go, oh no, that's awful. This is the worst thing that's ever happened, right? Or we have like all or nothing thinking. Like, I don't know if I tell her I'm upset about this, she's going to break up with me. CBT might address the thought and the core belief and then add well, what if you try telling her? And let's see if the thing you're afraid of happening actually happens. And it's hard to get clients on board with that sometimes. Here's how I would frame it, right? If it's really a big deal and it's something they've been wrestling with for a long time, I would say, well, I've noticed over the past little bit that this really seems to be holding you back. And it's a lot of weight and tension that you seem to be carrying. And so, I wonder if this is something you want to continue to do. Like if you imagine your life a year from now, scale from 0 to 10, how happy are you if you're still holding back and not being honest with your girlfriend about how you feel when she does certain things? And if my client goes, I'm too, like I'm mad at myself if I'm doing that. Okay. So maybe it might be worth an experiment to see because you're right and she's going to break up with you. And how long do you want to fight that battle? Or it might be possible that you're wrong and you're misinterpreting and this goes a different way. What do you think? And again, we're not trying to manipulate, we're just offering you can experiment with this if you want. And if my client says no after that, cool. It's a no, right? You have to maintain their autonomy in this. And we'll talk about that some more in the ethics part. Okay, so the goal overall is to adjust the way we think and believe to increase adaptive responses. Um, a goal for a client could be to reduce symptoms of anxiety to improve functioning. I'm okay with goals written like this as long as we include this positive thing that they're working towards. So to improve functioning. Or you could even phrase it like my client will improve functioning by reducing anxiety symptoms. That's probably a better goal, honestly. I like the positive, what are we working toward more than what are we trying to get rid of? It's easier to work towards something. Yeah, so CBT usually begins by educating the client on how to identify faulty thinking and belief patterns. That's why knowing the names of cognitive distortions is really helpful because if you can teach them the name, it just helps them understand it better. And then almost all interventions focus on challenging thoughts to change feelings and behaviors. That's true. So if you need to list 3 interventions for CBT this week, if they're all focused on thoughts, that's fine because most of them are. Like these. So questioning, I won't read through these. Y'all are more than welcome to look at them. But questioning in a challenging way, right? Really avoiding yes or no questions. The downward arrow, so working back. If we identify the behavior and we need to work all the way backwards to the core belief, then we would go behavior, feelings, thought, beliefs. So wherever you can identify in that cycle first, you want to try to work backwards to the core belief underneath it. If you can only get to the automatic thought, that's fine. Um, but your goal is to get to the deeper root of the symptom. Thought recording is great. Cognitive restructuring is good. Some people call this reframing, just thinking about it in a different light. Behavioral activation is good. Social skills training. So all of these are great CBT interventions. I think on your assignment, you just have to list them. But if you want to put a brief definition with it for your own learning, you're more than welcome to. Okay, so CBT process, it begins with formal cognitive assessments, and those continue through therapy. Basically, we're always looking for the automatic or unhelpful thought in CBT. Um, so it is unique because it does have a collaborative approach. So both the client and the counselor are responsible for evaluating thought patterns. The counselor is the expert in already knowing what core beliefs sound like, knowing how to name cognitive distortions, and understanding the cycle. So again, we're still teaching. So like we're the expert in that at the beginning. Ideally, our client is becoming more and more of an expert in those things. Um, and they're a student, they're a collaborator, they're responsible instead of passive, working to become an expert on how CBT works, and remembering that the client is always the expert of their experience, right? So whatever they tell you, you go with that as their subjective lived experience. And we start to compare that to what we can observe objectively. So you're not arguing that they're wrong. You're always just offering a different perspective to see if they agree or if they can take that on. Okay, so multicultural considerations. So some cultures emphasize yes, while others emphasize either or, which could create challenges with cognitive restructuring. So instead of, it's almost like we can become very black and white or all or nothing in our thinking. And so, like, we're trying to get our client from not this negative belief to this positive belief. And we might have clients that it's easier for them to accept, well, yes, this negative way I looked at it is true. And it's also true, this other more positive or even neutral way of looking at it. And so just understanding you don't have to get them to completely abandon the negative or unhelpful thought or belief. If we can add an and that the client accepts and believes, that's just as helpful usually. So clients who place high value on family, social expectations may not embrace the idea of choice. This is very true in like more collectivist cultures, right? Um, where kind of in the US, we've been all about individual responsibility and freedom forever. Where you might have a client who wants to make a change, but legitimately feels like they need to run it by their family first. And so just having open conversations about that. Where I would say something like, hey, my perspective is this. And I want you to know that I'm coming at this with that perspective so that I don't accidentally impose anything on you or go beyond my role in your growth and experience. And that's part of treating them as a collaborator, right? Always coming back to almost like the person centered, the client is the expert. I'm here to help them towards their goals, not create their goals and push them a certain way. That's a helpful mindset to have that keeps you open and curious and does help you avoid a lot of these things. Okay, so ethical considerations, again, informed consent as always. Competence, are you competent in applying this approach? Probably, because you can review a manual and understand it. Being careful not to impose values. And if you notice, there's some specific ACA codes in here you might want to include in your paper, right? Um, so start with reality first. Beliefs that accurately reflect abuse, racism, or danger are not distortions. So if someone's in an abusive relationship or experiencing discrimination or in legitimate danger, it's not just an irrational thought, right? We have to determine safety first. And if any of these are actually happening, we're not addressing that through CBT. We need to do something else, like a safety plan or um, a harm reduction plan, or have the client, if they're ready to do something more direct about this, helping them figure out what that is, right? So treat homework non-adherence as clinical data. It's not non-compliance or moral failure. Like when I was seeing a counselor, she would give me homework like every week. I maybe did it 50% of the time. And what she started to notice is that when I didn't do my homework, it's because we were either on something really important or she was asking me to work through something that I had already worked through. And so once she noticed that pattern, me coming back without my homework done, I actually didn't feel shame in it after that. And she was able to use that as kind of an opening for a discussion of like, does this feel like something you've worked through already, or is this something that made you feel uncomfortable about addressing? And that was always helpful. Okay, so restoring homeostasis, I'm going to skip this slide. I put it in here because of an old version of the worksheet, but you guys don't have that this week. So, choice theory, reality therapy. Honestly, one of my favorites. I used to hate it. Now I love it. I'll try to go through this one a little quicker than CBT. But it proposes we have five basic needs: love and belonging, power or achievement, freedom or independence, fun or enjoyment, and survival or self-preservation. Now, notice some of these are synonyms, right? Love and belonging is the only and that's important, but it could be power or achievement, fun or enjoyment. And when these needs are not met, this is kind of the underlying premise of choice theory and then reality therapy, is that when these needs are not met, we make choices to either pursue them or protect ourselves. So reality therapy would say that all behavior and all decisions that we make are an attempt to pursue our basic needs or to protect ourselves. And that's a really helpful framework for understanding what our clients do sometimes, and honestly, for understanding what we do sometimes. If you do something out of character, or you notice you're developing a new habit or pattern, asking which of these needs am I trying to get, or what am I protecting myself from, can be a very insightful question to ask. So total behavior, right? So we can control our choices even though they're largely unconscious. Now, before that, I would add we can't always control our environment or our situation, but we can control our choices. And this is hard because you come at it with some clients, and this can be a very shame-invoking concept that you're in control of your choices. And so taking a second to reframe it as there's no shame, because is it really fair to say you made this choice and blame you if you weren't aware that you had the ability to make a choice, right? That's where this unconscious piece right here comes in really handy. Now, though, that we realize that you can make choices, deciding what you want to do differently, again, no shame in that. It's just now you can choose something different. So let's not waste time feeling shame because of what we did when you can experience freedom and autonomy now, um, by doing, thinking, feeling. What do you do with your body? And realizing you have a choice in each of these areas. So this is fun. He would include emotions and behavior. So if you're feeling depressed, um, it's not you are depressed, you're being depressing because your situation is whatever it is, but your feelings and your thoughts and what you're doing, you have choices. And right now, if you're just sitting in depression, you're being depressing because you're letting each of these other parts of your behavior feed into that depressing cycle. This is hard. This is a rough thing to deal with. It's one of my least favorite things to realize is true, but it is. Now, that being said, you want to be careful in how you approach this with clients, right? Because you can say this in the kindest way possible and you still sound like a jerk and they still might feel demeaned by the way you address it. So, with caution, focus on rapport, make sure you have the relationship to introduce this idea before you try to go there, right? Oh, and what do you get out of it? So, if you're being depressing, there's something you're getting out of it, even if it's just nobody bothers me when I'm depressed, or I can call out of work and not have to go deal with people when I'm depressed. You're getting something out of it. Again, it's just true. If you're getting really upset about this idea right now, I wonder if there's something in your life that matches this and it's hitting a little too close to home. Because that was true for me. That's what it did for me. And I didn't like it. But then when I accepted it, it helped a lot. Okay, so the presenting problem for reality therapy is almost always an unsatisfying or missing relationship. Dysfunction is the gap between the quality world and the world the client perceives. So the idea of what the world is or could be and our perception of it, or what we want the world to be and our perception of it. Notice it's almost existential, right? Um, that lack of alignment and the four inescapable truths. Clients choose ineffective total behavior to try to meet one of the five basic needs. So symptoms are best understood as an attempt to get control, right? They're using whatever they have available or whatever worked for them in the past to try to gain a sense of control. Again, if you start to understand behavior that way, it's really easy to not get upset with people. And I think, actually, I know it's made me more empathetic because I'm not judging the behavior. I'm wondering, what are they looking for? Like, what are they really trying to get out of this right now? He doesn't like illness language, so depressing. Um, it's chosen, though largely unconscious. So he doesn't really like the idea like substance use for Glasser. Substance use is not a disease. It's not an illness. It's a choice, even if it's not a choice today, because it's such a habit. At one point, it was a choice. At one point, you decided this is what I'm going to use to escape. This is what I'm going to use to try to protect myself from pain, right? And if we can get underneath that, then we don't need a disease model. We don't need to understand substance use as an illness. It was a choice, which means we can choose something different today, even if we don't feel like that's true right now. So, and the choice is ineffective, not the person. So, you're actually, I would even say something like alcohol abuse probably was very effective and might still be very effective because if your goal is to escape and to not feel and to not have to deal with it right now, getting blackout drunk works. Is it healthy? No. Do we want to encourage it? No. Does it work? Absolutely. There are ramifications of that choice, though, that cause bigger problems and really ultimately make it ineffective. Because do you have to deal with it right now? No. Is it still going to be there when you wake up and you're hungover and feeling awful? Probably. So what are you really protecting yourself from if that's true, right? Okay, so roles. Your role is to emphasize choice and responsibility, a very present focused approach. You can talk about outside there and then, but you don't want to go all the way back to childhood. Really framing it as today, right now, today. What are choices that you can make to have a different outcome or to get something different? Maybe get what you actually need. So identifying ineffective behaviors, help clients find effective methods to meet five basic needs. So again, effective, I would toss in there safe and legal ways to meet the five basic needs. Because drinking might be very effective. How's it actually impacting your ability to have your five basic needs met? Right? Again, counselor is more of a mentor or teacher. It's very common in these CBT adjacent approaches. WDEP model is great. It's a great intervention that we'll probably talk about. Client self-evaluates, takes responsibility, chooses the goal, and commits to a plan. This part right here is probably the most important. Your client chooses the goal. You can help them choose the goal, but you better not choose the goal for them, right? We're already tiptoeing around accidentally imposing values, so it's better if we're more hands off on that part of it. Hey, look at that. WDEP. This is how you can help clients choose their goal and commit to a plan without imposing values is very strictly holding to this model. So what do you want as an open-ended question? That's the W. And we take whatever our client says. The only time I would challenge a client is if they say, I want to stop drinking. Okay, that's a not doing thing, right? How can we change that to what you want to do? Like instead of drinking, what would you like to do? and they say, I want to have, I want to be able to talk to people that I trust when I feel overwhelmed. Cool. There we go. And we understand not drinking is part of that, right? But it's much easier to pursue a positive than it is to get rid of a negative. That's a behavior therapy concept, right? That's why we focus on reinforcement and not punishment, because it's easier to replace with something new than it is to only get rid of something bad. Okay, so what are you doing to get what you want? This is how the drinking comes in, right? Well, right now, what I do is I go get blackout drunk every night. Okay, how's that approach working? It's not. I feel super lonely. I don't have people that I talk to every day, right? So what would you like to do different? What can we plan to do that would help you get towards what you want? Well, okay, so every day when I'm leaving work, I actually stop and think, I could go out to dinner with these guys, or I could just go home and get drunk. And I go home and get drunk. So maybe like once or twice a week, I can go hang out with the guys from work instead of going straight home and getting drunk. Okay, I like it. And then we try it and see how that goes. Now, what you have to be okay with as the counselor is that means your client might continue drinking, right? And unless it's a intense high level of risk, we kind of let it because we're slow change is the best change because it's going to stick for longer, right? It's more persistent, more permanent, slow change. So if they start going out twice a week and then they come in and they say, when I go out with my friends from work, I come home and I drink a little bit, but I really don't have time to get drunk like I normally do. Okay. So our plan is working and we start building on that success. So as counselors, we have to be patient, right? Um, and just this part, an effective counselor would act like a true friend in this process and challenge half-hearted responses. At the same time, we encourage wholehearted small steps, right? So whatever we changed worked. Cool. How do you think we can build on that, right? Or if they say, you know what, I thought about going out, but I didn't. Okay, what happened, right? Again, we're evaluating. We thought that would work. You didn't go at all. So what happened? What got in the way? What made that difficult? What do you need next time to maybe follow through? How do we change the plan to be closer to what you'll actually do? Right? You can act like a true friend because true friends are honest and they're kind instead of nice. Because the nice thing to say is, oh, that's okay, no worries. The kind thing is, hey, you said you wanted to work on this and then you go home and you give it a half-hearted attempt. That doesn't convince me that you actually want to make this different. Right? Again, plans are simple, attainable, measurable, immediate, involved, and continuous, and growing over time. Because doing this twice for a couple of weeks is probably what's attainable, and it's simple, right? 3 months from now, what's attainable might be, hey, every night you're going to go hang out with somebody. But that's too big of a jump from where we are right now. So again, treatment interventions. So questions, open-ended questions, right? What do you want? What do you need? What do you think about this? How did that affect you? What feelings come up for you? Being positive and genuinely positive, not just optimistic. But when your client does something that works, celebrate that. Be happy, right? You don't have to always be positive if there's nothing to be positive about. Honesty's better, right? Metaphors, humor, confrontation. Again, stay positive, even humorous, but we don't accept excuses. Paradoxical technique. So this confrontation, what that looks like in reality therapy is my client comes back and says, I was gonna do that. I did it one night, and then for the rest of the time between then and now, I didn't do it. I would I would probably say something like, so you did it once and decided it wasn't worth it anymore? And they go, no, not that it wasn't worth it. Okay, well, what was it then? Because like You said you wanted to, and I believe you want to. Like you had me convinced last time I talked to you. Hear the positive there? Not being optimistic. If that's true, say it. Like last time you wanted to do this, and I believed you. But like what happened? What came up? What changed? Well, I felt like awkward around my friends at work. I didn't know how to communicate. Okay. And then, you crack a joke or whatever, but we don't let them get away with it, right? We don't accept excuses as long as they said they wanted to, right? Now, if it was my idea and they agreed to go try it, you could also say, well, that kind of makes sense because I'm the one who really came up with that. So maybe we need you to come up with it so that it's something that feels like you can actually do, or at least that you actually want to do. So what do you think? Maybe we change it and you come up with the next step? That's a good move too. So ethical considerations. So you can disclose the non-diagnostic stance. We assess, document, and refer still. And you're going to have a diagnosis if you're private practice or in a facility. You can still disclose, like, I don't put a lot of stock in that. It's just to help us understand what we're addressing. It's part of your plan. But I don't put a lot of stock in like generalized anxiety disorder. It only helps me as much as it helps me understand what you're going through, right? Let's see. Again, so choose your behavior. It doesn't apply to abuse, trauma, or oppression. We have to recognize that there are objective experiences that go beyond choice, right? Now, can you still choose how you respond inside of that? Yes, absolutely. Like if you're in an abusive relationship and you've convinced yourself that you can't leave and can't get out of it, it's probably not true, right? Now, is it worth it to try to get out of that? That's a completely different question, right? It's still their choice about what they want to do inside of these, but we never blame and we never paint being in an abusive relationship as something someone willingly stepped into, right? They might be making choices that are keeping them there, that we still don't talk about it like it's what they want, right? Because it's not, they're trapped. And the same, like, this doesn't feel like a choice is very true and very strong because they're not choosing for their partner to abuse them or for their parents to be abusive. That's not their choice, right? And the ways that they've responded probably are protective, right? So you want to be very careful with these topics that I would even say if you're not sure you can paint this correctly in these situations, use a different approach. That's kind of the short and sweet of it. Confrontation requires safety screening, and you want to build that alliance first. Um, Paradoxical technique, obviously, don't tell someone, well, why don't you just go home and cut as much as you want? Not what you do. Again, maintaining boundaries, right? And then just being aware of culture and power differences when we start to use that humor and the direct approaches. Again, homeostasis, we don't really need it. And so, yeah, here are your references if you want to take a look at those. Um, Actually did pull this from the 2025, the more recent Murdoch textbook. Yeah, if you have any questions, feel free to reach out, let me know. Also, you can rewind the video, watch it back. But yeah, if you have any questions, as always, feel free to reach out.